So the skin's grossly made up of two layers, epidermis and dermis. Epidermis is the outermost of the layers, and the epidermal layer provides a barrier to infection from environmental pathogens and regulates the amount of water released from the body. The epidermis is composed of multiple layers of flattened cells that overlie a base layer composed of columnar cells arranged perpendicularly. The epidermis primarily consists of keratinocytes, which compose about 90% of its cells, but also Langerhans cells, Merkel cells, inflammatory cells, and melanocytes. The dermis is a much thicker layer, and it's divided into papillary and reticular dermis. And the structural components of the dermis are collagen, elastic fibres, and extrafibrillar matrix. You can see the blood supply extends to the upper limits of the dermis, and the epidermis itself gets its nutrition via diffusion. And we'll talk about why that's relevant later on. The skin contains a number of sensory nerve fibres, the Pacinian corpuscles, which respond to mechanical deformation, and Meissner's corpuscles, which are a mechanoreceptor. When magnified, you can see the epidermis is made up of basal cells and squamous cells, amongst others, and the melanocytes sit at this basal layer producing melanin. So in the case of melanoma in situ, the cells become irregular in size and shape with uncontrolled growth, but remain within the epidermis. They can't invade as they can't get to the blood supply. In melanoma, those cells invade into the dermis. Melanoma is the second most common cause of cancer death in 15 to 34-year-olds, with a steady incident in both females and males. The mortality rate is still going up in males and improving slightly in females. There's about 2,500 deaths a year in the UK. Causes include obviously UV radiation to sun, and indeed childhood sunburn causes a doubling risk of melanoma. Family history, so the fact that they've had cancer, which also in turn affects your skin type. So the lower the Fitzpatrick, the higher the incidence. And then your genetics itself, so if you've got a CDKN2A, CDK4, MC1R, they increase your cancer risk, as does BRCA2 has a slight increased risk, and the rare disorder of xeroderma pigmentosum. So the history must include, and this is a Jonathan Pollock sentence, but the temporal course of the lesion. So that should be the presence and the change in the site of the lesion. Make sure you know about things like itching and bleeding, which is not too uncommon, and whether they've had any previous lesions, especially in those patients where it's a melanoma of unknown primary. They may have had an innocuous little mole taken off a few years ago. Family history should include other cancers and melanoma, and past medical history includes or needs to assess a risk such as immunosuppression, and then the appropriateness for surgery. So whether they could have a general anaesthetic and whether they're on any antiplatelet therapies. Smoking history, sun history should include sunbeds and holidays. Clinical examination includes macroscopic and dermoscopy assessment of the size and the site of the lesion. And ABCDE is one of many different ways of assessing lesions, and is not a bad way. Lesion assessment should continue though with full dermal mapping and assessment of nodal basins and systemic examination.